Hi everybody, I am Dr. Tejas Shah from Diabetologist from Mumbai. I am here for the 50th annual RSSDI conference held in Chennai for 2023. So my session today here was titled Sulfonylureas and the importance of sulfonylureas in today's practice. So as we all know friends, sulfonylureas have been a cornerstone of therapy in diabetes, in type 2 diabetes for a number of years. Maybe more than 4 decades we have all been using sulfonylureas. Earlier we had the first generations, then the second generation, and now we are up to the third generation of sulfonylureas. Why we are talking on this topic today is because in the last decade or so or more than that, we have had the advent of number of new drugs in the management of diabetes. We have had the DPP-4s, we have had the SGLT2 inhibitors, we have had glitazones, alpha glucosidase, we have newer insulin and analogues. And therefore, the place of sulfonylureas in the management of diabetes has been challenged a bit. So, they are wonderful drugs, no doubt about that. What I spoke about today here also was the same. All these drugs have their place in the therapy of diabetes. The ominous octet of diabetes is such that there are different pathophysiologic defects and we need different therapies to target these pathophysiologic defects. And therefore, sulfonylureas is one of the, you can say, one of the drug in the armamentarium of diabetes, which targets the pancreas in a different way. It causes release of insulin. By stimulating the release of insulin, it causes reduction in blood sugars. The area where sulfonylurea scores over other drugs is in terms of its efficacy. We know that they are the most efficacious drugs in terms of reduction of HbA1c. An A1c reduction of more than 1% is usually seen when you use a sulfonylurea. There are certain points which are debatable. There are certain points which we are talking nowadays more is because of like hypoglycemia, the risk of hypoglycemia with sulfonylurea, the risk of weight gain, and the cardiovascular safety. And these are the points basically I spoke about in my talk today here. Yes, hypoglycemia is a concern with sulfonylureas. The older generation sulfonylureas, that is the second and first generation, had more severe episodes of hypoglycemia. The newer ones like glimepiride, glyclazide, they worked in a different way. They work by binding to the 65 kilodalton receptors on the beta cell, and therefore they are more judicious in terms of insulin release. They do not cause prolonged insulin release, and therefore the incidence of hypoglycemia becomes comparatively lesser and safer with these new drugs. But yes, they can cause hypoglycemia. When you compare them to newer drugs like DPP-4 and SGLT2s, those drugs definitely score over sulfonylurea when it comes to hypoglycemia. Weight gain is a myth, I would say. It doesn't happen because of the drug per se, but it more or less happens because of the overall reduction in glucotoxicity, the reduction in glucoseuria that happens because you are using a sulfonylurea. Coming to cardiovascular safety, there have been again controversies related to sulfonylurea and cardiovascular safety. The older generation one like tolbutamide showed some increased cardiovascular safety in the UGDP studies way back in the 60s, and from there on people were talking about cardiovascular safety with a sulfonylurea. But again, various trials till now have shown that they are cardiovascular safe. I am not saying that they are the best drugs to be used for a patient with cardiovascular disease. Naturally, the guidelines are telling us that you use a SGLT2, you use a GLP, you use these drugs much earlier, and that's what we are doing in clinical practice. But the sulfonylureas again do not have any cardiovascular toxicity. If you look at the Carolina trial, which we spoke about here today, it is a head-to-head comparison with a DPP-4 linagliptin, where it was found to be non-inferior, or glimepiride was found to be safe and non-inferior. If you look at various meta-analysis, again they have shown that the cardiovascular risk and cardiovascular mortality does not increase with the sulfonylurea. So the take-home point for this is that these are drugs which are good, these are drugs which are very efficacious, but as the guidelines tells us, you need to select a patient, you need to be sure when to add this drug. Now, for a newly diagnosed patients, we have better drugs. So naturally, you start off with lifestyle, we start off with metformin, and then you choose a DPP-4, you choose a SGLT2, you choose a GLP agonist, and if not under control, you then go on to a sulfonylurea as maybe a third drug to add on. For a patient coming to you with a very high HbA1c, maybe the newer drugs are not enough to reduce the blood sugar to the desired level, you may have to add a sulfonylurea much more earlier than a third drug, or maybe from the very beginning. So it will all depend on patient to patients. These are still very efficacious drugs. These are drugs which in India, especially where the average diagnosis of HbA1c is very high, I am strongly believing that you cannot do without a sulfonylurea, and we need to use it, but use it safely, use it at a lower dose, which is more important rather than going to a very high dose. Use the newer sulfonylureas which are more cardio safe, which can cause less hypoglycemia, and I think they are still drugs which would be very useful for a longer period of time. Thank you very much.